Hi everyone, I'm Shane Galver, I'm a postdoctoral research fellow here, and today Hilary Bowman-Smart from University of South Australia is going to talk to us. Before she does, I'd like to acknowledge the tradition of Aboriginal custodianship of the country on which the campuses of the University of Sydney stand, and in the case of those of us here in person, the land of the Gadigal people of the Eora Nation. We pay our respect to the knowledge embedded within Aboriginal custodianship of country, wherever we live and work. So Hilary is a research fellow within the Australian Centre for Precision Health in the University of South Australia, and she's an empirical bioethicist with a background in genetics and philosophy. Her ethical and philosophical work is informed by various types of empirical research, such as surveys, statistical analysis, and qualitative interview studies. And she's focusing currently on reproductive ethics, genomics, and the philosophy of medicine. So we will have a lot to learn from you. So,
hi everyone. Thank you for having me. Yes, so I'm a researcher at the University of South Australia, but as of Monday, I'm employed by Adelaide University. So that's exciting. And I also feel like that bio was perhaps slightly misleading because there is no empirical research in this talk at all. So just flagging that up front. So this talk, I suppose, is expanding on a talk I gave at ARBL in December last year. And it's just kind of emerged from a lot of the work that I've done previously has been sort of in prenatal screening and diagnosis and that sort of thing. I was interested in the question of what is the diagnostic process doing and what makes a formal diagnosis in particular sort of legitimate outside the clinical setting. And so I ended up sort of making a bit of a foray into philosophy of language. It's not like I have a extensive background in philosophy of language, so I do extend sort of apologies to anyone who is a philosopher of language. Apologize in advance if I make any errors. But yes, so basically that is the title of the talk. What do we do when we diagnose emerging technologies and epistemic authority in the diagnostic process? No. No. Okay, so diagnosis can be understood as a category and also as a process. So this is a distinction made by Meredith Laxter back in 1978, talking about alcoholism. So as a category, that's sort of the classification of disease. We might be talking at the higher order level of sort of nosology and manuals and ICD-10 codes and that sort of thing, but also a construct that's applied to an individual patient. So you have diabetes. As a process, it is, of course, that process of, that's sort of the next slide, deciding what the diagnosis will be. And the diagnosis as category, of course, influences the diagnosis as process because that is usually has the diagnostic criteria. But the diagnosis as process also influences the development and refinement of the diagnosis as category. So what is the process of diagnosis? So it's often presented as like a detective hunt or a puzzle just to find out the cause. So, obviously like a house MD, et cetera, there's something wrong and we need to figure out what's causing it. So it's really about this idea of finding the root cause. It can also be, so Anne-Marie Dutel is a sociologist of diagnosis. And one of the things she talks about is like building a narrative about how the signs and symptoms fit together. And when someone comes to, say, a GP, they're often coming with as sort of the start of a story already in mind. So I think the example she gives is like, you come with a sore wrist. Two things may be true. You've recently taken up mountain biking, and that's the cause of your sore wrist. Alternatively, this is around the age when your mother developed rheumatoid arthritis. And so deciding which sort of narrative to perhaps start with kind of shapes that kind of narrative building. It can also be more of a sort of process about figuring out what to do next. So Sedegzadeh refers to this as clinical praxeology. So it's about figuring out, it's not so much just about figuring out the cause, it's about figuring out what to do next. And of course, there are different dynamics in the diagnostic process. So it can be sort of a negotiation, if a patient comes seeking a particular diagnosis, or a collaboration, or there can be tensions and conflicts and so on and so forth. Of course, the thing that is very important to recognize here is that humans are not cars. So the subject of diagnosis is usually a person as agent, though of course we do have dead people, fetuses, etc., etc. A car, when a mechanic diagnoses a car, runs diagnostics on a car has no strong feelings or preferences about what is to be done or what it thinks is happening. But people do have feelings and preferences about what is to be done and beliefs about what they believe to be the cause of their signs and symptoms. I'm sorry, you can't see that. Diagnosis and the boundaries of medicine.
I haven't heard anything.
Pardon?
I just, every time someone gets admitted, it brings down the meeting controls again. Sorry. I think we can stop that.
So diagnosis as a process is a means of establishing the boundaries of medicine or mapping its jurisdiction. And in particular, formal diagnoses, which often serve an administrative or bureaucratic function, they play a central role in the journey through illness, treatment, recovery, management, healthcare institutions and bureaucracies, so hospitals, the Medicare benefits claims, etc., but also social and political systems and services, so like the NDIS or the disability support pension, or all of that, kind of thing. And formal diagnoses therefore have significant material and psychosocial consequences. My focus today is less on sort of the ethical issues and inequities in diagnosis, but more, I guess, this conceptual question of what is happening. What are we actually doing when we seek and provide formal diagnoses? And when I say we, I am not a medical doctor, so it's perhaps slightly presumptive. But so I'm just going to start with an example here to illustrate, I guess, in particular, the importance of formal diagnosis. So an individual identifies something is wrong. They're like, I feel crap all the time. They go to the GP. The GP runs, there's a screening test for celiac disease. It's a blood test, and it comes back positive. So the GP is like, right, I will write you to a referral to a gastroenterologist. So you get the first referral to the gastroenterologist. And that gastroenterologist does a biopsy, a gastroscopy. This is the diagnostic standard. They do a gastroscopy and take samples from the intestines and do a biopsy. It's a false negative because the gastroenterologist did a terrible job. And those results are obviously sort of returned to the patient being like, you have no sign of celiac disease. You don't have celiac disease. And you can kind of see two paths that may diverge here. So in one path, that person returns to the GP, they get a second opinion, a second biopsy, because the symptoms persist. And that second biopsy is a true positive, and then you have a diagnosis of celiac disease. The other option is the symptoms persist, someone goes to, say, for example, a naturopath, or they self-diagnose with something like gluten intolerance or non-celiac gluten sensitivity. And the naturopath might do some sort of test, etc., etc. This is partly based on my own experience because I have celiac disease. So, and so in this table, I guess I just want to illustrate some, pull out some key points. So formal diagnostic criteria, celiac has that. Gluten intolerance, no, or it's disputed. There's a test, there's institutional legitimacy, there's access to resources if you have a formal diagnosis, so things like access to a dietitian, discounts on food, all of that sort of thing. You do not get that when a naturopath says you have gluten intolerance. And I cannot underestimate the seriousness of this, social kind of accommodation and emotional accommodation, because if you just say to a friend at a dinner party that I have a gluten intolerance, some people will absolutely roll their eyes, right? Waiters will do a sort of a similar thing. And they may be less likely to if you say, well, I'm going to defer to sort of the epistemic authority of the doctor who diagnosed me. I have a formal diagnosis. My claim for accommodations is legitimate, essentially. And then this is down here, perhaps at the bottom, not so much a issue for celiac disease, but is an issue for many other medical diagnoses. Once you get a diagnosis, a formal diagnosis, it's very sticky. It's very hard to de-diagnose something. You know, in terms of it's in the file, you know, maybe a patient forgets about it or something, and it comes up, you know, 5 years later when they're getting a driver's license or something like that. Whereas something that's more sort of nebulous, like a general sort of this idea of gluten intolerance is easier to de-diagnose, essentially. So obviously, I'm not going to get too much into this, the very large amount of literature in this space. But obviously, the key thing here is that we often talk about the distinction between medical and non-medical as the distinction between you know, normal and abnormal, sick and healthy. But it's also a distinction between important, necessary, legitimate, and real, and unimportant, unnecessary, illegitimate, and fake. So, you know, a rhinoplasty is the same procedure, regardless of the reason. But, you know, someone getting it for cosmetic reasons, it's not sort of seen as medically necessary versus, you know, if a dog bit your nose or something like that, then it's medical and it's important. Whereas if you're getting it for other reasons, it's seen as vain, unnecessary, and you know, you often see these sort of words like fake. So I started sort of thinking about diagnosis, formal diagnosis, as a speech act, which is a theory from philosophy of language, which is looking at how when we say things, we do things. So the sort of classic example is marriage vows. So you have an officiant. The officiant says, you know, you've got a wedding, you've got, you know, two people getting married, and the officiant says, I now pronounce you husband and wife. By doing so, by saying that, something becomes real in the world. It shapes sort of social reality. And there may be other things associated, other sort of procedures or rituals like signing of a form and so on and so forth. So we can make a distinction between sort of locution, so like the literal meaning, illocution, which is what the sort of speaker is intending to do or doing, and perlocution, which is how it was received, how the person listening received it, the effect on them. There are many different types. It's sort of a way to understand the way we talk generally. And when we look at speech act theory, the reason why I think it's interesting is because when you look at something as a speech act, it's not about whether it's true or false so much. It's about whether or not it's successful or unsuccessful. Does it have force? Does it work? Or does it not work or not have force? So we often implicitly present a statement like, you have diabetes, you have type 2 diabetes, as essentially a constated, like an observation of fact in the world. But it really functions as a performative and a vindictive, a form of judgment by a doctor. And so a formal diagnosis is not just describing something or recognizing some objective fact about the world. It is making something happen in the world and applying a very particular explanatory and interpretive framework onto the world. So we might borrow from sort of Anscombe and Searle and think about a direction of fit, where a diagnosis is about a word-to-world direction of fit. So making the words make sort of something happen in the world and not a world-to-word direction of fit. So the statement is describing what is the case in the world. So here are just some examples with type 2 diabetes. So we have things like assertive, which is sort of, you know, proclaiming essentially a statement of fact or expressing a belief that something is true or false. And so here we might say, okay, well, there's the basic observation of your blood test is at this level. It's at 7.2%, etc. I also I'm not an expert in diabetes, so, you know. There's also if we go down further, we have directives. So you will need to do this, directing the patient to do something. Commissive, like promising to do something. So we'll follow up in 3 months, like committing to an action in the future. Expressive. This is often, you know, in diagnosis, like, I'm very sorry to tell you, or like, I know this might be hard to hear, etc., etc. And also things like interrogative, like, have you noticed feeling thirsty a lot lately? Have you been tired? What have your symptoms been? But the ones I'm most interested in, obviously, which is why they are highlighted in color, is the vindictive and the declarative. So the vindictive is making a judgment. It's providing an expert judgment and is like legitimizing the diagnosis as a clinical conclusion. The declarative is making something real. It brings a new sort of social or medical reality into being through that utterance. You have type 2 diabetes. I am now recording it in a form, and so on and so forth. And that can have an effect or perlocutionary force on a range of actors, on institutions. Now, you know, if the doctor said you have type 2 diabetes, you can go to the pharmacist and get insulin, perhaps subsidized insulin. It can legitimize your requests for you know, accommodation at work and so on and so forth. It can help the patient feel like that, you know, their experience of illness is being recognized as real. And there can also be speech acts by others that I'm not going to go into too much. So for example, if the patient goes home and says, I've just been to see the doctor, I have type 2 diabetes, that sort of speech act is citing what the doctor has said. So that patient is expressing what they believe to be a true-false kind of statement, because it's relying on the fact that the doctor has made that real and you know, made it to be the case. But of course, the formal diagnosis is only successful under the right conditions. So we think of these as felicity conditions from Austin, J.L. Austin, or we might also think about components of illocutionary force from Searle. So basically, the person giving the formal diagnosis needs to be the right person. They need to have a medical degree, currently, conferred with a particular type of epistemic authority by virtue of expertise, the right procedure, so the diagnostic guidelines or criteria have been followed, right tests have been done, invoking a valid category like an ICD-10 code. It needs to be the right circumstances, so symptoms, test results, etc., all line up with the diagnostic guidelines or criteria. Right intention, so sincerity is important, like the doctor isn't committing fraud. And then we might also think about degree of strength. There's an important difference between a doctor saying, maybe you have type 2 diabetes, and I think you have type 2 diabetes. I'm writing this, essentially, recording this on a form. So here is an example to illustrate when a speech act of formal diagnosis may be successful or unsuccessful. So you have the same statement, which is you have type 2 diabetes. And for example, we might have the right person. This man is a doctor, but it is not in the right setting. He is at a party in a bar, telling his friend, who he has not done any diagnostic tests on or anything like that, that you have type 2 diabetes. We often do this, like, you know, we sort of talk with our friends and, you know, someone says, oh, I'm tired all the time, I'm thirsty, etc., etc. No, you know, someone might say, well, sounds like you have type 2 diabetes. And that has a function. It prompts the person to hopefully go to their GP and get tested, but it doesn't have the force of a formal diagnosis. And there can also be things like the wrong procedure, which might also include things like testimonial injustice. So the patient's testimony about their signs and symptoms has not been taken into account. So what I suppose I'm interested in is that formal diagnosis is used for resource allocation decisions all the time. And this is outside the clinical setting. So we're taking what is essentially a clinical judgment or a clinical decision, but we're using it in a sort of policy setting or a legal setting or a social setting. And so because formal diagnosis is sort of being inappropriately being used as a heuristic in decision-making for resource allocation outside the clinical setting, this in turn means that we need to rigidly police the boundaries. Because, you know, everyone says like, oh, do they really have celiac disease, or are they really gluten intolerant, et cetera, et cetera. So we often talk about diagnosis as though you go to the doctor diagnoses you with type 2 diabetes, then you get resources. But what happens equally is that you go to the doctor, you get a test done, the doctor looks at the values and says, look, you're on the borderline, but if I diagnose you, you'll get access to a continuous glucose monitor, or if it's sleep apnea, if I diagnose you with moderate sleep apnea, you can get a CPAP machine, but if I write down mild sleep apnea, you can't. So, sounds like you have moderate sleep apnea to me. So in that sense, the resources, it's actually is really fundamentally shaping the medical diagnosis. And you know that this sort of circular impact is obviously most pronounced with sort of borderline cases where there's sort of ambiguity, where that can be, you know, really strongly shaped. And this is where the sincerity condition is interesting, because I think you can argue that the doctor is very, very sincere in their moral judgment that the person deserves that resource, but less so perhaps their medical ones. The medical judgment is kind of just instrumental. And I think the reason this is useful is because sometimes you hear statements like, oh, everyone has XYZ nowadays. Everyone has this, you know, blah, blah, blah. It loses its meaning. Well, why does it lose its meaning? If everyone suddenly gets, I don't know, there's some sort of supernova and we all end up with, you know, needing glasses, that doesn't really matter. If there's enough glasses to go around, it doesn't really matter. Everyone, you know, has some sort of vision issue. But because it's being used as a sort of around the sort of decision-making for resource allocation, it is a problem if everyone has the diagnosis, because then it has absolutely no utility for assigning resources. And this is why I think self-diagnosis, people find self-diagnosis very, very annoying. Not just, oh, it's not true or whatever. They find it annoying and frustrating. And I think this is because self-diagnosis is perceived as entitlement. People are entitling themselves to resources or things that they do not actually deserve. It's not just a sort of epistemic claim about what is the case for me. It is a claim to, when I go to a dinner party, you need to have gluten-free crackers for me, basically, which is obviously a low-stakes situation, but you can imagine much higher stakes situations. So a formal diagnosis is not just about disease. It is about dessert, because it's about resource allocation in these very kind of like material things like the disability support pension or NDIS packages, but also social and emotional kind of resources. I don't know if that's the best way to sort of think, but sympathy, accommodation at, again, dinner parties. I'll just bring back that example. Acceptance if someone is late all the time, and so on and so forth. And because of this, it changes what the utterance is doing. Because what we might say is a formal diagnosis, it's a medical judgment that has a sort of downstream effect on moral resource allocation. But I don't think that's quite true. I think as a speech act, it can also be a vindictive, a judgment, as a moral judgment, not just a medical judgment, which is to say, I judge you as being deserving of resources. And those resources, so that's who should get what, who we should accommodate, and who should be permitted. So who should get what, like who gets access to prescriptions or treatments. Many medications are on the PBS for certain diagnoses, but not others. So a doctor might write down a diagnosis so that a patient can get the medication for $6 rather than $200. Also, yeah, who we should accommodate, so workplace and social accommodations, but also who should be committed to do things or take things, and this is most obvious with drug use, because if you find that you cannot function without dexamphetamines, you can't hold down a job, etc., but you buy your dexamphetamines from a man on the street, that makes you a moral reprobate and a criminal and illegitimate. Whereas if you then can find $3,000 to be able to pay for the assessment, then you can buy it legally. You are a morally upstanding citizen. The stigma is sort of managed or reduced. So it also functions in that way as well. So onto epistemic authority. I'm like 3/4 of the way through. So the way our medical system is set up is that doctors are functionally gatekeepers of diagnosis. If you need a diagnosis to get access to medications or to get something from work or to get etc., you need to go to the GP. So it's adding a lot of like this diagnostic labor onto doctors that often is not really serving any particular clinical purpose. An example is I was working on a project. GPs in small towns are often asked to do capacity assessments for the local solicitor doing a will. But a medical capacity assessment is very different from a legal capacity assessment, and so on and so forth. But so formal diagnosis requires a person with a very particular type of epistemic authority, i.e. a doctor, to declare it. So it's the social and institutional recognition of a speaker as a credible sort of knower. The fact that the authority has a belief P is a reason for me to believe P. And that may depend not only on the credentials, but again, trust, setting, perceived neutrality, and so on. And without this authority, if you don't have this epistemic authority, listeners will just not accept it as real. There will be no uptake. It won't have the effect. I can go around saying you have type 2 diabetes all day, but it will do nothing. Sort of from an institutional perspective. So a self-diagnosis may actually be entirely correct, but where someone says, "Oh, I think maybe I have celiac disease. I'm not sure," they're making a vindictive sort of judgment, but within the bounds of their essentially like epistemic authority. But when someone says self-diagnosed very confidently, "I have celiac disease," they are making a vindictive, but people don't like this because it is basically someone overstepping the bounds of their authority. And so doctors are vested with institutional, legal, and social authority to make formal diagnoses on the basis of their epistemic authority. But we do have, there's these concerns around sort of health misinformation online, a bunch of other things that I will get to in a later slide, that may lead to an erosion of institutional authority. But I think maybe as well, an issue is that we may be mistaking the boundaries of their epistemic authority, because again, if we assume that they are making a medical judgment when they're actually making a moral one, now a very experienced doctor, that seems sort of reasonable, but they don't necessarily have sort of a degree in ethics. They've probably got basic medical ethics training. So there's a range of circumstances when the functional role of epistemic authorities are not fulfilled. So you can have fake and unintended authorities. So fake, basically, you straight up sort of charlatans, grifters, and so on, snake oil salesmen. Unintended authorities, you see this often with like academic papers where someone publishes something very niche and then it gets splashed on the front page as proof that, this gene cures cancer or whatever. And then we also have unrecognized authorities. So they may be untrusted, like international medical graduates who haven't been accredited here. Unintelligible, they might be speaking a different language or, highly technical information or something like that. Or unknown. They might just not be known. We might just not have heard about them. So if we look at, this is a very condensed table, I'm sorry. An example of, I suppose, different people in the diagnostic process and the type of epistemic authority they have. You might have like a specialist, like a gastroenterologist or an endocrinologist. They're up there, up the top. General practitioner also pretty high. They're often sort of the first institutional step in that process, but their authority to make certain diagnoses may be limited, so that there may need to be specialist referrals. The patient has context-dependent epistemic authority, as does their caregiver. There's also the pathology lab technician. They have high epistemic authority, but their domain is the test and not the interpretation or diagnosis. Then there's these questions around machine learning models, which is two things. What should their epistemic authority be? And secondly, how is that sort of being, what sort of authority have they been given in practice? Health organizations or bodies, they're very high because they're often the ones deciding what the diagnostic criteria are. Like in the late 90s, they changed the cutoff for type 2 diabetes or type 1 diabetes. Suddenly you have many people who were perfectly healthy and now have undiagnosed diabetes. A naturopath, wellness influencer, they're low, but they may be perceived as having epistemic authority by some, but that's not recognized sort of by institutions or in many social settings. So there's a lot of emerging technologies and social changes that sort of prompted this, and I probably should have also put this slide at the start now that I'm thinking about it. We have things like direct-to-consumer or at-home testing. So that might be direct-to-consumer genetic testing, and that might be, useful. Or we also have things like MTHFR testing, which is where someone can do a direct-to-consumer test for an MTHFR variant, which has been essentially used in the kind of alternative health wellness space for a kind of litany of things, like if you have a particular MTHFR variant, you can't have vaccines, et cetera, et cetera. But also COVID, screening tests at home, the rapid antigen tests. Machine learning diagnostics increasingly being integrated into clinical care. We have straightforwardly kind of the discriminative models, which might be looking at X-rays, like imaging data, but also increasingly things like generative AI, like chatbots and so on in that diagnostic process. Genomics and disease prediction, the amount of information that we can produce, the value and legitimacy of self-diagnosis. Private digital health clinics are one that I'm very interested in. I don't know if you've heard of these. You may have been advertised to you on Instagram. If you are on Instagram, they are very well sort of designed, and they're basically, there's one called like Juniper, it's women's health. You sign up $500 a month and you get mail order Ozempic. It's legal because a doctor said it was fine. So basically there's that kind of setup as well. And then we also have questions like the changing scope of practice in the medical workforce. So nurse practitioners, pharmacists are increasingly allowed to make a sort of limited number of diagnoses, like UTIs, for example. So if we're looking at these sort of in a bit more detail, machine learning models, there's the question of, when ChatGPT says something, is that a speech act? Well, there's no intention behind it. You could say, even if it has an effect on the listener. But in a sort of low resource, time poor clinical setting, you can imagine essentially the machine learning model spits out something like this patient in the ICU has an 87% risk of pneumonia or death or whatever. And the concern is where a clinician essentially defers or just repeats that statement rather than judges it in the same way that they might judge a readout of a list of numbers or from a blood test or something like that. And in particular here, something that is interesting is the difference where if you have a machine learning model that has an output of a graph versus an output of a using natural language processing that's like, hello, Dr. So-and-so, I've assessed the patient's case, and I think the patient has an 87% risk of pneumonia or whatever. There's actually sort of, it obviously depends a lot on context and that sort of thing, but some concerns that where it's natural language, the instinct is to treat it like a colleague who's emailing you rather than a machine that is giving you information for you to judge. And so you run the risk of sort of automation bias there. And again, that connects to this question of, is it just the same as any other blood test, or is it meaningfully different in some way? The private digital health clinics, as I mentioned, so the doctors working at these clinics do have the authority, but I think there are questions to be asked around whether or not there is the right procedure and whether or not there is the appropriate level of sincerity in that formal diagnosis. And then with genomics, we have predictive diagnosis, so someone being diagnosed with Huntington's disease many, many years in advance of symptoms being experienced. That Speech Act transforms them from a healthy person to a sick person, as opposed to someone who's already experiencing symptoms. They're transformed from undiagnosed to diagnosed. Risk is increasingly understood as a formal diagnosis in and of itself. So a BRCA1/2 variant is hereditary breast and ovarian cancer syndrome. Reclassification of variants, again, can sort of transform the status of a particular individual. And again, also this direct-to-consumer testing with sort of pseudoscientific claims around particular genetic variants. So, main takeaways. Formal diagnosis can be understood as a speech act. And the reason why I think this is interesting is primarily because it has helped me understand how and why it's important. How is it working, I suppose, is the interesting question. So when we look at it through this idea of felicity conditions, I think it helps us understand what makes a diagnosis legitimate. Doctors have the appropriate epistemic authority for the Speech Act to have force for now, but there are questions around this being eroded or relocated, which may have impact on the force of those Speech Acts and introduce new authorities who can make those Speech Acts. And because formal diagnosis in the clinical setting is used for resource allocation outside the clinical setting, this means that the boundaries must be very rigidly policed. Because if you have to have XYZ in order to deserve something, and we have a limited number of somethings, we need to really figure out, be very, very clear about what it means to have that condition. So the diagnosis as a medical judgment legitimizes the disease. Sorry, that was meant to be disease. The diagnosis as moral judgment legitimizes desert. The end.
Thanks very much, Hilary. We've got time for questions. We'll, we can get the main screen showing. We keep an eye on the people who are online who are looking to ask a question. I'll take a couple from the room and then come to you after that, Seamus.
Oops, Hoji and Kate that I saw.
Okay. Hoji.
Thanks. My question is about your characterization of diagnostic process only in terms of speech acts.
Mm-hmm.
So I get that there's this aspect of diagnostic process that can be framed and probed in terms of speech acts, but I think there's also an earlier step in the diagnostic process that is not just about speech acts. And so to give an example, and it doesn't operate under felicity conditions. Actually, I think at least ideally should operate under some form of falsifiability conditions. So a doctor looks at this test result, and because we have this proposition that if it's beyond a particular figure, then based on the evidence, okay, it seems that it's suggestive of diabetes. So I think, so I frame it as an objection to your account, and then you perhaps challenge me on that. Do you think that, so the objection goes like this, that your account omits or doesn't take into account sufficiently the earlier phase of diagnostic process that does not operate under felicity conditions?
Yes, so I think that is quite compatible because I'm really just concerned with for the purposes of this presentation, it's almost like the whole clinical reasoning step is a black box. And the black box, basically, I'll take it on trust whether the clinical reasoning was the right procedure, the right, the appropriate diagnostic criteria, et cetera, et cetera. There's a lot of really interesting stuff around sort of clinical reasoning. So for example, people think, you can think about things like symptoms, but you can also think at a higher order level of like problem identification and so on and so forth. I guess to illustrate an example, in a resource poor environment, a war zone or whatever, a formal diagnosis doesn't really matter as much because what really matters is essentially the clinical, like if you've got a broken leg, it doesn't need to be necessarily recorded on a form or whatever, because navigating those administrative and bureaucratic kind of systems is a lot less of a priority than a clinical diagnosis. So I suppose I've tried to separate the role of diagnosis in clinical decisions and in the clinical setting to the role of the diagnosis outside the clinical setting, if that makes sense. So I agree that the whole thing of Speech Act may not hold very well for all of the much richer kind of stuff that's actually happening in the clinical sort of reasoning process. But yeah. Kate.
Hi, Hilary. Thank you. This is really interesting. I have two small questions for you. So the first question is about large language models and speech acts. So, because I think overall I buy the picture. So I think my question is, so perhaps LLMs don't have intention, but they can do locutions and they can do perlocutions. So does it matter that they can't do elocutions? Especially because they can do perlocutions, and that's often, I mean, I guess it depends on whether you're kind of like conventional about it or not, but perlocutionary acts are sometimes taken to be the more important side of it. So that's kind of question one. Question two, I think, yeah, you're right, that definitely diagnosis matters for dessert. And then I was thinking through as well, though, that maybe a part of the moral picture is that it also provides excuse. So I sort of wondered what you thought about, moral diagnosis and excuse.
Yeah, so with the excuse, I think that's very interesting. I've sort of focused a bit on the ways that diagnosis can unlock things, but it can also close things off. Obviously, there's a huge amount of literature in philosophy of psychiatry, obviously, that I sort of have not really gone into here. Absolutely, like if a diagnosis sort of becomes a reason for sort of all of the things that you cannot do, et cetera, there is a sort of risk that it may have that kind of like negative impact rather than sort of directing people towards resources or support or accommodations or so on and so forth. So I think that's definitely true. I agree, basically, yeah. And also because people can have a sort of, that a formal diagnosis can have that effect on someone without the doctor wanting it to, of course, all the time. With the machine learning models thing, there is like a hearty debate, I think, about the nature of kind of machine learning models and speech acts and so on and so forth. I think the critical thing is exactly as you've said, the force, the force itself. Currently, what we have now is with these human in the loop kind of systems, the idea is that like, it's basically like a proxy. A clinician still has to come along and say, yes, no, I agree. I give the sort of stamp of authority. I think the concern is where, again, you're in a busy hospital, and obviously machine learning must take a variety of, you're in a busy like radiology kind of clinical, whatever. And there ceases to be that level of interrogative kind of judgment, which might be okay if the model is like fantastic, but obviously the concern is that essentially it's just like the utterance just kind of gets repeated, and as soon as it's sort of repeated, it's not repeated as a judgment in and of itself. It's repeated as a sort of citation of something else.
Seamus, hello. Go
Hello,
ahead.
everyone. Thank you, Hilary, for a great presentation. I spent a few years of my PhD interested in many of the same questions. And so I suppose I have a bit of a comment and a couple of questions. One thing that I became interested in was speech act theory as it relates to diagnosis, but not so much via philosophy, so much as sociology, and in particular the work of Pierre Bourdieu in books like Language and Symbolic Power, and his essay on the legal field. And Bourdieu makes a compelling point, I think, which is he talks about how the way that it's within the legal field, that speech acts ultimately in the final instance can gain their performative force. And so I'm interested, and ultimately the conclusion I came to when it came to diagnosis as a speech act is that even though most acts of medical diagnosis don't get tested in a legal setting, in the final instance, that is where their authority is tested, and sometimes reaffirmed, but sometimes undermined. I ended up reading a lot of case law for my PhD and read endless court case transcripts and read about how judges in their judgments weighed up different forms of medical evidence, medical testimony, expert testimony. And in their final summing up and their final decision, it was the judge who determined at the level of a social reality which was the right diagnosis. So I think that I mean, I suppose that's what I've been interested in. I think it's pretty compatible with everything you're saying. And so I suppose I was wondering if you have any views on where the authority comes from, or what are the conditions that are required to actually, create the performative force of a diagnosis. In my view, it's through the law, but you might have other ideas. And I suppose my second question relates to the kind of historical development of the gatekeeping role of doctors, which seems to me to be historically specific and bound up in the development of the modern welfare state. And it was not the case for doctors in the mid-19th century that they had a gatekeeping role, and their acts of diagnosis didn't have the same level of performative force because they hadn't yet been given a specific role within society in the welfare state. And that very much ties into your point about resource allocation. And so my second question is about the kind of technology-based diagnoses, and if you have any thoughts on whether they will still ultimately need to be kind of superintended by medical doctors acting as gatekeepers who, in a sense, are fulfilling a key social function for the welfare state. Because if they're not doing that, then couldn't there be the risk that handing diagnosis over to technologies could result in mass levels of diagnosis and uncontrolled resource allocation that the welfare state kind of has to keep a very close eye on in terms of being bean counters? So apologies for that very long-winded question, but I spent 3 years looking at this and I'm very interested and passionate about it, so it's hard to restrict myself.
It's fantastic. I'd love to read some of anything you wrote if you want to send it to me later. So the second one, the resource allocation, it's kind of interesting because some sort of in some kind of institutions and systems and whatever, there's been a move towards like needs-based assessment or like functional assessment rather than just like solely allocating based on diagnosis. But I think that just basically ends up functioning as just diagnosis in another form, in another taxonomy, sort of another classification. In terms of like that, honestly, I think the reason that the epistemic authority of doctors is being eroded is not just because of things like social media and so on and so forth, but it is because our healthcare system is in crisis. So one of these private digital health clinics, literally their vision statement says that they are a solution to a healthcare system in crisis, for those who can afford to pay, of course. In South Australia, they've recently been running an urgency campaign. I see these billboards sometimes. And the thing is like, is it an emergency or an urgency? And so basically, essentially asking people to make that that their own self-assessment of whether or not their sort of symptoms are a real emergency, which people already do before they decide to go to the emergency, ward. So I think a lot of the sort of displacing, and this includes the questions around increasing the scope of practice in the workforce, a lot of that is driven by the fact that we don't have enough doctors for rural and regional areas. And well, we don't have enough doctors generally. So the system, the administrative and the resource allocation system and just the whole healthcare system is set up to have doctors as this bottleneck point. And that works okay if you have enough doctors, but as soon as you don't have enough doctors, it starts to go into crisis. And so you're basically at a point, well, we have to allocate some authority to pharmacists, to other healthcare practitioners. And that may be good or that may be bad. I'm just sort of saying that's the driver, really. I think that mostly answers the second question. The first question, the legal thing, I think this is interesting because I was mainly interested in it at first, again, more so in the social setting, and these sort of questions around like informal diagnoses, like unwritten diagnoses and so on and so forth, but also just like basic questions of like, yeah, waiters and dinner parties and whatever. But part of the reason why waiters ask you, like, do you have an allergy, is in part because of legal requirements. Like the UK introduced new legislation a couple of years ago because a girl ate a roll with sesame seeds while on a plane and unfortunately died on the plane. So they introduced these very strict requirements. And as soon as that happened, everybody in restaurants got very sensitive. And when I said, oh yeah, I have celiac disease, they're like, we can't serve you. Like, sorry. So oddly enough, I stopped saying that. So, so I was like, is it gluten-free? And they're like, yes. And I'm like, great. I'm very hungry, so I'm just gonna risk it. So in a way, these kind of like social, this social legitimacy does in many ways trace back to literal legal legitimacy. I don't have a strong background in like sort of law or philosophy of law, so I haven't quite come at it from that angle. But there's also, of course, things like moralizing things around like, again, if someone is tired all the time, if they don't have a medical condition, they're lazy. If they do have a medical condition, they're not lazy, et cetera, et cetera. That's, we all sort of know that. So it's almost like maybe that's a side effect of the legal authority that's placed in doctors. Like the doctors have the legal authority because we need to figure out how this person died. So we know who killed them or whatever, or we need to know if there was malpractice or et cetera, et cetera. And then, in social settings, it's almost like you make a sort of, you default to the sort of, well, legally they said this in this court case, so that's the case. So maybe that was just me thinking aloud, actually. So I don't know if that answered your question very well. But
Thanks.
Yeah, that's great. Thank you.
Thanks, Hilary. Now we've got a little queue and not a lot of time. So Gabe has a question.
Well, I guess it's similar to what Seamus asked and maybe what Hoji had as well. I was just thinking that one of your big point is that we must police the boundaries of formal diagnoses. And then my thoughts immediately go to, well, who are the police? And insofar as you view diagnosis as a speech act, which constitutively includes moral judgment, which is likely to be variable amongst the medical population, and you have declining or problems with erosion of epistemic authority, the conclusion that I would be led to is that you can't police boundaries, or it's going to become more and more difficult, at least insofar as you're looking at some sort of internal self-regulation by the profession. So then who are the police?
So to clarify, when I said the diagnostic boundaries must be policed is not a position I hold personally. It's more of a, if this is the case, if it is used for resource allocation in this way, in the allocation of very scarce resources, then the kind of immediate instinct is like, well, we need to be very, very clear about who's in and who's out. I don't think that's useful because it just produces increasingly artificial kind of sort of separations between people rather than sort of basing it on, you know.
But if it
need
is
or
used
other-
to distribute resources, then you should police it. And the law seems like a good. At the end, my question was before Seamus answered him, and I think that sounds like an answer.
Right, but I guess I'm saying they shouldn't be used, they should not be the criteria you use. You should use other criteria, things like, again, needs or some other form of assessment. They have their own issues as well, but using formal diagnosis alone turns it into like a blunt tool that can be sort of, you end up with populations who are overdiagnosed, you end up with populations who are underdiagnosed, because, you know, people are like, I want this resource or I need this resource or whatever, and then so working sort of backwards, I suppose. Does that make sense?
Yeah, I mean, if you use it at all, you should police it. But I don't think there's anything wrong with that outcome. But yeah, amongst other things, seems like a good idea.
Yeah. I think the concern is more in things like, less so again in the clinical setting, and more so in things like disability support pensions, NDIS, that sort of thing, where again, it's true, the decisions need to be made. Decisions do need to be made. I guess the concern is when the decision sort of gets sort of reduced to a very binary yes/no question. Do you have it or do you not have it? Rather than a more complex sort of assessment. But then, of course, a more complex assessment is very expensive. So.
Hey, thank you very much, and to you, Hilary, and everybody who asked such great questions. Hopefully I'll survive till lunch, during which time those of you who didn't get a chance to ask your questions can hopefully talk through some of their thoughts with you. So thank you very much.